All right. Welcome to episode 62 of the Jake Blanchard podcast. As always, we're brought to you in part by Stream to Sea. They're voted the #1 mineral-based sunscreen by Rolling Stone magazine. They're out there changing the world, helping you better preserve our rivers, our lakes, our oceans, and also keeping some of that junk out of your skin that absorbs into your body. Check them out, streamtosea.com. Podcast listeners using code JBP at checkout. Get 10% off your order. Also, Fellowship brand, premium men's grooming products. Their organic natural oils, balms, and butters. Their tattoo balm is something I use on a daily basis. And fellowshipbrand.com, JBP at checkout gets you 10% off. My guest today is Dr. Jim Souza. He's Vice President and Chief Medical Officer at St. Luke's Health System in Idaho. He's a board-certified pulmonary disease and critical care medicine doctor. He's received his degrees from the University of Washington, and personally, I had the pleasure of working under some of his guidance about a decade ago on some process improvement projects related to infection prevention. He's a man I have a tremendous amount of respect for, and I'm excited to chat with him about his career, his role as Chief Medical Officer and leader within St. Luke's Health System. We're going to talk a little bit about COVID as well and more topics. It's going to be a fun, open conversation. Dr. Souza, thank you for coming on the podcast, sir.
You're welcome, Jake. Glad to be here.
Yeah, for sure. Hey, let's get anchored in, man. Where originally are you from? And then take me through that trajectory that made you decide that you wanted to go into medicine in the first place.
Yeah, it was pretty accidental, truth be told. I'm from Billings, Montana. That's where I grew up. And I actually went to college to be a journalism major. That was my first major in college, and went to the University of Montana, which is a solid journalism school. At least it used to be. I'm not sure it still is. And the true story is I had an advisor during my second year who was asking me why I wanted to go into journalism. And I told him I want to be a writer. And he was like, well, print journalism is on the ropes. This was back in the 80s. And he's like, everything's going the way of talking heads. And, at that time I had a full head of hair and I was a better looking guy. And he's like, you got the looks for it, but buddy, you do not have the voice. And I was like, what? I can't change my voice,
Yeah.
And there was a guy on my floor that was a pre-med student, and I started talking with him, and I said, why not? That sounds kind of cool. I get to help people. And so anyway, the decision to go to medical school was actually it certainly wasn't a life plan. It's something I sort of fell into.
And then, so then when you get to medical school, isn't there a segment of like specialization, right? Or so you have to kind of declare kind of an area of focus. Did you picked, what is pulmonology disease? Like, I think I know, but like, why did you pick it? And then, maybe expand on that area of medicine.
Yeah, it was also accidental. I mean, this is a theme you're going to hear with me. I am not the type of person who with my career anyway, began with the end in mind. I just kind of focused on what I was doing, and then saw what opportunities came forward. Pulmonary and critical care is a specialty, which it's interesting. It's got dichotomous ends. So on the pulmonary side, you have long-term relationships with patients in clinic, right? I mean, I've got patients I've been helping care for more than 20 years now. Those are rich, they're meaningful. You follow disease processes over a long time arc. On the critical care side, your relationships with patients and families are very short, very intense. It's life and death, usually in a matter of hours to days, sometimes minutes. And so it's those two poles. And I loved that about the specialty because it was so broad. I think docs who work in emergency medicine, for instance, only get that one end, and docs who work in primary care only get the other end. So it's broad that way. But I honestly, I just sort of got to it accidentally. I worked with doctors that some of I call them my mother goose doctors, the ones who really imprinted on me. And at each step of my career, the first thing was I decided to do internal medicine because I couldn't decide what to do. And that's what you decide when you don't know what to do, because it's a broad field. And that was because of a physician I worked with who imprinted on me. And then in my internship year, I met a very influential and amazing humanist physician who was a pulmonary and critical care doctor. And that got me thinking about it.
Oh, very good. And so, there's a leadership layer that I think
Yeah.
sits on top of this as well. And so take me through, how long you practice medicine day to day versus like when did that balance of taking on more and more leadership roles within the organization kind of take hold? And how'd you find yourself as the chief medical officer today?
Yeah. That also started with an imprinting event. There was a physician in my training who was the leader of a training program and he was an endocrinologist. And the balance that he brought, I just was deeply impressed by. I got into leadership kind of accidentally in my group. I joined a private practice group in 1999, and there was a leadership transition happening, and nobody really stepping forward. So I stepped into that kind of void. And as it turned out, I mean, number one, I kind of liked it. Number two, I kind of had some talent at it. But probably most important, I noticed that if we actually had dedicated leadership, like all my colleagues we got more done. People were generally happier. To answer your question, I did full-time clinical practice with leadership as sort of a bolt-on between 1999 and 2012. In 2012, I took on a more substantial leadership role inside the St. Luke's Health System, and I've been practicing part-time clinically since then. And I still practice part-time, both in the ICU and in the pulmonary clinic to this day. It's progressively gotten smaller as the leadership role has gotten bigger. But I think that's really important. It's very important to me to maintain that connection to the reality on the ground.
I love that. Absolutely. And so when we start talking about realities on the ground, we have certainly had a very interesting 18 months across the United States. We've had certainly in Idaho is no exception to what's been going on around the world. Maybe let's just talk in general. What's it been like being a leader during the last 18 months with COVID and the pandemic and these types of things going on?
Yeah, it's been really hard, and it's been really rewarding. I guess that's the way I'd say
Okay.
it, Jake. I mean, the challenges have included just the pace at which we've really had to make decisions, and we've had to make decisions honestly without having all the information. I mean, if you go back to like the early days of the pandemic, I mean, we literally didn't know what we didn't know. And as you know, that's a bad position to find yourself in. And so you're making decisions based on the best information you can pull together. It's been also challenging because of, I think sadly, some of the divisions that this exposed. And that's once you see those things, you kind of can't unsee them, and so that's been a challenge. It's been really rewarding though too. Boy, if there had been any atrophy, and I'm going to just speak about myself, if there had been any atrophy in my sort of heart and mind in terms of the importance of what we do in healthcare, it's just been a really good reminder that this field that I'm lucky to practice in it actually touches every single life in some way, shape, or form.
100%.
Yep.
What an awesome point there. I mean, from the standpoint of, you talked about it a little bit earlier, you're still practicing, you're there on the front lines, you're engaging with these folks, and to be able to see that, and then to be in a role where, you've got to make some tough decisions, difficult decisions. You've got to change course in some areas. That's the nature of the job too, right? I mean, and so very cool perspective there. I want to auger in a little bit more on something you just mentioned, which was kind of the inherent division. It seems that COVID got really politicized, like really early on. Like, certainly every time we point a finger at somebody, we get 2 or 3 fingers pointing back at us, right? That's one of my favorite visuals there. But when we see different administrations taking different stances at different times on, various aspects of this, we've got, it somehow became a blue and red thing. It somehow became like a media outlet perspective. Instead, I feel like we're not having conversations as rational adults. I guess that's what I'm trying to say right now. And has that been your perception as well? Or is there kind of a silver lining there? Is there a lot of like really deep, meaningful conversations about the best path forward happening all across, say, medicine or the media? And maybe I'm just polarized and missing it.
That's a great question. I think, well, I think the trap we've fallen into is one that, I guess the way I'd say it is, there's quite a bit too much, I think, people bifurcating truth, if you will, into black and white, into right and wrong. And the truth of the matter, of course, is always populated with a whole lot more gray. I'll just use one example. And this gets at the topic of our recent decision to require vaccination. You do hear from some people in my field, in positions like I'm in, the vaccines are safe, with a period. And you hear from some of the countervailing opinion, the vaccines are not safe, period. I choose to approach this conversation in a way that is frankly more beneficial to all of us together, and I hope more beneficial to the person I'm having the conversation with. I'm never going to come out and say the vaccines are 100% safe. I'm always going to start with vaccinations have risks, and acquiring COVID-19 has risks. Can we talk about the relative degree of those risks? And if we do it that way, will that help you make an informed decision for you? This, finger pointing and right and wrong, it is terrible. I think it starts with leadership, which means, like, in my role, it's very important to me that I don't do that I engage people in a conversation about what's important to you. Why are you thinking about this way? Help me understand, and try to get to that conversation about risk. And then if I'm lucky enough and can take the conversation far enough, also get down to some really cool science about how the human mind gauges risk based on bias. The bias of the risk I take on versus that's a shot.
Yeah, no. I
versus
see it.
the bias of the risk of, something that quote unquote just happens to me. Jake, have you read the book Sapiens?
Oh yeah, Noel Yo Harari, for sure.
I'm going to be honest with you. I reached hope is really important for me. It's like hope gets snuffed, I don't do well.
Yeah.
That is one of the very few books in my entire life that I decided I couldn't continue to read. When he got to the point in the book where he's talking about how social media is taking his underpinning thesis and putting it on steroids, and how it might spell our doom. And you know, for your listeners, I mean, the underlying thesis of his book is that humans, what's made us the most successful and dangerous species on the planet, right, is that we have this unique capability to take something you can't measure, you can't see, called an idea, and weaponize it like a virus and spread it.
Yeah.
And we can create hive mentality in non-hive organisms. We're not ants and we're not bees, but we can act like that. We can get mothers to send their children off to die for a cause because of an idea. We can get a person to give up all of his belongings to follow a stranger for an idea. We can get strangers to come together to build a cathedral for an idea. And then at the point where, and I was like, yeah, that's cool. That's all true. And then he was like, and now it used to take a long time to weaponize your idea. It took a lot of energy, a lot of networking, a lot of time, a lot of people, a lot of conversations. Now you can take your phone and just hit forward.
Yeah.
It's frightening how that is contributing to our natural tendency, I think, to want to hear. It's a confirmation bias. That's a natural human brain thing. And social media platforms feed our confirmation bias. So everything I do tries to get around that.
Yeah, absolutely. And maybe unpack that that decision to mandate maybe a little bit more, if you don't mind, as far as vaccinations in the facility. Where's that coming from? What data is kind of backing behind it? And then, you know, again, and many of these conversations we'll have around COVID, I'll represent the question and maybe a differing opinion, just to kind of draw out the underlying aspects of the conversation.
Absolutely. This was for us a time sensitive decision. So, you know, I don't know exactly when this will air, and I don't know what will be happening at that time. So I should maybe just say that at the start of my comments. Why did we make the decision? Because we couldn't look at what we knew anymore and continue to stand on the non-requirement position as healthcare providers. So let me unpack that. What did we know? At the end of June, the Idaho Department of Health and Welfare put out data that from January through June, 98.7% of our hospitalizations and I think 98.8% of our deaths in Idaho were in our unvaccinated fellow citizens. So, you know, the numbers it was in the ballpark of 2,500 hospitalizations, and like 35 of them were in vaccinated individuals versus, you know, the remainder in the unvaccinated. And the deaths were even more lopsided. It was like 450 or something of our fellow citizens died, and 5 of them were vaccinated. So we were looking at that data. We were looking at our internal data trends on our employees' COVID-specific call-offs. So they were going up and up and up. We were looking at the safety data that existed. You know, again, if someone says, tell me how you know the vaccines are safe in 10 years, the honest answer is, I don't. But I can tell you a comparison. We have 18 months of data with COVID, what that looks like long-term, and we have 17 months of data with vaccines and what that looks like so far. So we were looking at that data set. We were looking at how long will it take the FDA to move from EUA to authorization. And the fact is, the average, I don't know if they're going to speed this up, but the average is about 12 months. And then, you know, we came back to our mission and our obligation. And, you know, not all healthcare workers perhaps see it this way. I think those of us who are physicians, we did take, we're a profession, right? And we actually all sort of took a vow.
Yeah.
I think people, the Hippocratic Oath never actually said first do no harm. I don't know if people know that. There was something kind of like it, kind of buried in it after, praising Apollo and all the gods and all that nonsense. But after World War II, the World Medical Organization, and I think it was because medicine sadly was sometimes used in that conflict to justify some of the atrocities that happened. The World Medical Organization came together and they dusted off the old Hippocratic Oath and created a new oath. And it's got two commitments. The first is that I dedicate myself to the service of humanity. And number two is I put the needs of my patient first, even ahead of my own. Even ahead of my own. So when we looked at the data coming in and those value sets, we basically wrestled with. It then became a matter of, all right, this can't be if, it's only when. And as when health and welfare came out with their internal data, we were like, we got to act now. We cannot lose another employee to this preventable disease. We cannot have another employee hospitalized with this preventable disease, and we can't have another long-term disabled employee from this preventable disease. So that, honestly, it was safety for patients, safety for our people, and the data that was coming in that moved the timing.
Yeah. And so maybe, and I appreciate that answer, by the way. That's a very detailed and clearly a lot of things to think about. And I love the tie back to the Hippocratic Oath and putting in a perspective of, the viewpoint of the health system on how the care providers can ensure the patients are getting what they need and creating a safe environment for care. Just kind of looking it through the lens of somebody who's not in the medical field or who's not working in a health system every day. There has been a lot of, I don't want to say changing, but changing in policy around certain things. So we heard early on, there's a lot of conversation around the origin of this particular virus, and there was a lot of political whatever. And I don't have a dog in the fight. I don't know. Was it animal transfer? Did it come out of a lab? I have no idea, and I'm not going to profess to. But the thing that really struck me as unnerving early on was face masks in general, right? Because what we had was a clear statement made that face masks actually early on, hey, they're not really going to do anything unless they're N95s, et cetera, et cetera.
Right.
And then a couple months later, all of a sudden you can't go anywhere without a face mask on.
Right.
And I think that for a lot of people was really concerning. And it still kind of is because, we're starting to see folks going back to a face mask policy electively. I think health systems are, some schools are, certain businesses are electing to do it. So what's your viewpoint on the face mask and then the kind of the varying opinions around, how effective they really are in helping to prevent transmission?
Okay. Yeah. I think the underpin, I get it. When you're dealing with a fast moving situation and you peg your true north to science, I think there's a misconception that that science is also black and white.
Yeah.
Nothing could be further from the truth. I mean, the underpinnings of the scientific method are actually to have a mental model that's something like this. I will never know the truth. I will only get closer and closer to an approximation of what the truth might be. Because with science, right, you put out hypotheses, you test them, you accept them, you refute them, and then you make the next hypothesis. So the very underpinnings of that being our North Star meant that the goalposts could move. But I don't think that was well communicated, nor was it well understood. So I get the confusion that was created. On whether masks work, they help. And I'm going to use one of I use metaphors and analogies a lot. I don't know if you remember that about me, Jake.
Oh, I sure do.
um, early on there was this is silly wearing a mask because a viral particle is way smaller than the holes in the mask, and that's like saying a chain link fence is going to stop a mosquito. Well, there was a lot of learning in how this virus spread in the early days, and it's actually continued to now with this Delta variant. The analogy, you can use the mosquito analogy, but then you got to say, well, my mosquitoes ride on tennis balls. And then a chain link fence most definitely does stop a lot of the skeeters. Now, the fact is some of the skeeters are riding on little pinballs, which might go through that chain link fence, but it's a partial barrier for the larger respiratory droplets, which are loaded with virions in an acutely infected individual. So, it helps. The other thing though I'd say, and I got my mask sitting right here next to me, is like it only helps if you do it right. And doing it right, I mean, how many times do we all see this?
Yeah, for sure.
Or this.
Yeah.
And as a respiratory doctor, I like to do the little test with people. I'm like, plug your nose. Now breathe in. Now cover your mouth and breathe in. See, they're hooked up. It's all like one system, like a snorkel. So if you're going to wear a mask appropriately, it needs to fit right. It needs to cover both nose and mouth. And this is another reason why masks are just far from perfect. Because whatever, you get hot, you get sweaty, somebody can't hear you, and so you pull it down to make your point more clear, and then you spray them with a bunch of aerosol. Anyway,
And it's interesting as well, is just because like a lot of people are reusing the masks that they're using all the time too. So it's like, I mean, there's certainly, I know my son, and I understand his school's doing the best that they can, but during this whole thing, he was back in class, and he left his in a class, and a teacher just opens a random drawer and grabs a mask out of it and hands it to him, and it was homemade. It was like, and I'm like, where was the origin? Like, who was touching this thing? Like, what?
yeah.
Why would you give a potentially unsanitary, rag to my kid to put over his face?
Gross.
Because, the thing is, they're following a guideline, but like the thought process behind it about it, like exactly how to deliver those typical, and so it kind of takes away from the validity or like the weight of it if you're not, to your point, following the protocols kind of correctly. So what are those? Mask covering your face, you dispose at the end of the day or during the day, or like what's that? What should we be doing if we're going to don a mask?
Keeping it clean and keeping it to yourself. I mean,
no sharing. You can't share them.
Gross.
I'm just joking. Come on, man.
I mean, there really aren't a lot of risks with masks unless you're a very small person and couldn't remove it from your face. I mean, like it actually could occlude an airway.
Yeah.
But beyond that, it's just like basic sanitation and cleanliness. I mean, just like if you don't brush your teeth, if you wear the same mask 30 days in a row for long periods of time and breathe into that, you're going to get some interesting, you might get some interesting things growing in there. They're largely, by the way, going to be harmless to you because they came from you. They already live in your mouth and your nose, but it's just gross.
Yeah, for sure. Absolutely. And as we're continuing to kind of unpack different areas of COVID, let's talk about treatments.
Okay.
Like this is an interesting world as well. I did some some bro science research. Okay. I looked the things up. I go to the CDC site. I went to the World Health Organization site. I listened to a couple podcasts. I did some research. By no means am I an expert on treatment protocols for COVID, not pretending to be, but the thing that I do see is there is some variability on perspective of, the usage of corticosteroids versus remdesivir versus things like prophylaxis, like hydrochloroquine, when that was originally talked about. There's some mounting evidence in countries like, Mexico and India for the use of ivermectin, which was not really on the radar necessarily, and some pretty pronounced pulmonary docs like Dr. Corey and Dr. Merrick, who have come out and like really talked about ivermectin's benefits. So like, what's your perspective then on like the treatment protocols and the evidence that you're seeing out there, and how do you respond to the needs of individual patients with different medications, and how do you take in evidence for things that are going outside our world here in the US, or maybe our traditional treatment bubble, to incorporate that in?
Yeah, good question. Maybe the first thing I'll do to give you some context for what's actually happening on the ground in healthcare delivery right now, because it's challenging for frontline providers. I think because of our information bubbles, because we are largely now interacting with a patient population. When they get sick enough to come to the hospital, they're overwhelmingly in the unvaccinated population. I'm not going to make a generalization about that population. It's actually, there's pretty diverse. It's a pretty broad spectrum, but I'm going to say that there is a larger percentage of that population that has been consuming information maybe from less traditional sources of medical knowledge. So what's tough for providers is that we're increasingly being faced with folks who show up with a desperately ill. Actually, there's two things I want to say about this, and why, I tend to agree with the Surgeon General that misinformation is actually making a real public health issue right now. From personal experience, Jake, I have cared for individuals who decided to take bad advice, which was to delay their care. They were already infected, getting very sick, and they decided to take hydroxychloroquine and ivermectin and high doses of vitamin D for a day or 2 days before presenting to the hospital in extremis. At that point in time, the things that we know that actually can impact that phase of the illness, like corticosteroids, sort of like the die was cast. We've missed our opportunity, and I have personal experience with some of those ending in death, needless. And I just don't know if I can. I don't know if I can express adequately in words just how devastating that is.
Sure. Yeah, 100%.
So that's happening. And then the other thing that we're starting to get is this kind of, I'm going to describe it a bit as an armored up, hostile sort of, I'm coming with, this is my recipe for how I expect you to treat me. Almost like your doctor is your line cook. Like, hey, I said scrambled, not poached. What are you doing? And so that's getting in the way of what really should be there all the time. And what should be there all the time is a relationship between a provider who has a fiduciary responsibility to a patient. And people get mixed up in that word all the time. They think it has something to do with money. No, it's the second part of that oath. I put your needs even ahead of my own. in this relationship. That's how I've got more knowledge and training about all this biological stuff that is currently impacting your health. And I'm going to put your needs ahead even of my own. And we're going to come together and share our decisions and make a decision together. I don't know any doctors who, faced with questions about, doc, should I be taking ivermectin? Wouldn't have a conversation, or shouldn't have a conversation. They should. Or, doc, what about vitamin D? Let's talk about that. But what's happening is that the information silos are eroding trust in the institution that might be required to actually save your life. And then when the time comes to actually engage with that institution, maybe your preconceived notions are so firmly entrenched that it becomes less a conversation and more like an arm wrestling match. And it's just completely non-productive. On ivermectin, I'm aware that there are, I think, very large studies going on. I'm aware that there are smaller studies that have suggested benefit. It definitely it hasn't made it into the quote unquote mainstream in Western medicine, but perhaps it will. Perhaps the evidence will come in saying that that's the case. In the meantime, Jake, my thinking is we tried Plaquenil. I ordered Plaquenil, hydroxychloroquine early on. This is when we didn't know what we didn't know. And we had a protocol where we were using it. And then as the science became more clear that it actually doesn't help and actually it's harmful, then we rolled that back. So we had to change our mind. And that confuses people who don't understand that the nature of science is to change your mind. Steroids. Early on, it was like, I remember giving advice. Use steroids if there's another indication, but don't use steroids for this. And then the big studies started coming out of Europe that, whoa, there's a real benefit here. And we changed course. Change is going to be the name of the game with this.
Absolutely. So, pulling on this thread a little bit more around a general distrust. I think that there are a lot of people out there that are feeling like they're having their voices suppressed for just asking questions. And I've certainly seen this because I've been one of those people who I'm inquisitive by nature. Like I host a podcast too. I like bringing people on and having conversations like this to shape how I feel about things. And to your point earlier about just it being black and white, I feel like you kind of got put into one of two camps, like really early on. And then that became your echo chamber around those two camps. And now when people are trying to come out of them to ask questions, I kind of feel like, at least to the folks that I've talked to in the medical profession, where I say something like, it's like, man, I really don't, I'm not a big fan of wearing masks. I'll just tell you that. I don't like putting cloth on my face, and I want to question it as often as I can just to try to get this thing over with as soon as possible. That's my perspective. But when I bring it to somebody in the medical community, they've been just hit with so much opposition that they're already at like a 9 or an 8 when they talk to me about it. And they're like, put on the damn mask, and so like I think there's a tension on both sides. And I think that there's certainly people out there that feel like they can't ask questions because then they're kind of looked at kind of stupidly. And I feel the same way about vaccinations as well. I think there's people out there who are like, yeah, we feel like maybe we don't know the long-term impacts of this. I'm in a healthier age demographic, as in a lot of the people who have passed, and correct me if I'm wrong here, I'm swimming in the deep end, but advanced age, comorbid conditions, potentially overweight in some way, shape, or form. There's all kinds of risk factors that increase your probability of death. If you're within those realms of where you're not in these huge risk factors, why should I have to put something that I don't know into my body? And I think that's the question. And if I ask that question, why am I the bad guy? So any perspective on kind of that outlay?
Well, so there's a couple things in there. I think on the topic of everybody being at a 9, I agree, and it's a major problem. One of the, I think one of our internal most profound, and for me, my most profound lessons from leadership in the pandemic was how critically important emotional intelligence is, and the skill of listening, and you know, casting bounded optimism. It's going to be tough, but we're going to get through it. So that goes beyond leadership. All of us could be more emotionally intelligent in how we interact with our fellow human beings. Because in those, in those conversations, you get to understanding, and there's almost nobody that I can't find significant common ground with, even though we might start the conversation pretty anxious and revved up in our positions. So humility, listening, we all need to do more of that. On the topic of, why should we all try to get a vaccine? I'm just, again, I'm stuck in the way I think about things. It's assessing risks.
Right.
And then with this Delta variant, it's created a new dynamic in this conversation. And it goes something like this. I don't think that, personally, I don't think we have evidence yet. And I don't think it will turn out that the Delta variant is more lethal than the original SARS-CoV-2. Some people see that our average age of patient dropping from 69 to where it sits today in our hospital system at 56 years is a sign that it could be. I say no, that just shows you that the older population is more adequately vaccinated. I think that's probably what's driving that drop in age. But this virus is doing what viruses do, especially RNA viruses. It's becoming more perfect. And perfection for a virus is replication. The most recent data, well, let me say this first. So with the original SARS-CoV-2, early on in the pandemic, I was really curious, like how many replicative events occur in every human we infect? There were some interesting studies done on that, and it's a pretty broad range, 100-fold difference, but it's between 1 billion virions and 100 billion virions that every infected individual creates. With the Delta variant, which is known now to be about 225% more infectious than the original SARS-CoV-2, about 50% more infectious than the UK variant Alpha. We know that the number of virions produced is between 100 to 1,000-fold higher. This is the new perfection the virus has created. It makes more of itself. And in making more of itself, it's able to infect more aggressively and make more of itself. That is an interesting dynamic for the young and healthy. And it's not necessarily for the acute illness, because you're absolutely right, Jake. The risk of death and severe hospitalization for someone as young as you is small. It's not zero. We have a completely healthy young person. I won't state an age or anything like that in one of our facilities. I'll only say less than 30 years. Who is 5 weeks in now, and if they make it, long-term survival probably will require transplants. So I mean that happens, but it's really rare. I'm more worried in our young population, and here at St. Luke's, we're in the population health management game, and so I'm going to tell you, I am white-knuckled on this topic. We already know that at least 10%, as many as 30% of people who survive COVID have some sort of long-term symptoms. And we don't understand that yet. We're starting a clinic here at St. Luke's. But when you get into the population health management game, as we are, meaning we're taking population health financial risk, per member per month payment, per member per year payment to manage the health of a population. And you know that there's now a population of young people who should be low consumers of healthcare, where, oh my gosh, 1 in 10 of them has some sort of prolonged symptom and they're going to need healthcare resources. Brother, this country is not designed to handle that population health disaster. I hope it's not going to be a disaster. I hope these symptoms kind of run their course and maybe 2-3 years out, they kind of melt away. I don't know. Sitting here talking to you today. And so that is that. And so when you combine those two things, well, we don't know the long-term effects. We know the new virus is so much more contagious that literally walking past someone for a second or two, there's enough cloud of virions that you can actually get infected. That to me is a concerning cocktail for my message. Lately I've been saying, when people ask me, what's your advice, Dr. Souza? I'm like, 3 things. Get the vaccine, get the vaccine, get the vaccine.
Oh, sure. And, I appreciate that perspective once again. I think one of the major concerns here is to what ends, right? I mean, so we're going to have booster vaccines. We're going to have this variant and that variant. And I think what we're doing is we're opening up a door long-term to a different way of being. And I think that's what a lot of people are concerned about, is that they're going to be mandated to have basically foreign chemicals put into their body on a regular basis for their health. How long until they have an adverse reaction? How long until that doesn't impact them? Like we're increasing probability as time goes on. And I get why people are really fearful of it. I get why people are fearful of not being able to be employed if they're not willing to do that for a long time, because it kind of handcuffs them in a lot of ways. And maybe as we're kind of rounding out here, what's your response to that perspective?
Did you see Jurassic Park?
I sure did.
Yeah. I think it was Jeff Goldblum who he has this line in there, life finds a way. Viruses, in as much as a virus is alive, it's going to continue to find a way as long as we allow it to. You might have caught wind of the Lambda variant in South America now. And one of the mysteries of Brazil was, if they had such a walloping, and they did, initial surge, and so many people got infected, why did they have another surge? And the thinking that is starting to emerge, and this is, Jake, honestly, this needs to still be in the realm of speculative. But it's pretty concerning if it were to turn out to be true, is that the unique 5 amino acid mutation in that Lambda variant seems to lead to an evasion of the immune response in people who are infected. And therefore, immunity, in the original SARS-CoV-2, right, there's studies that are showing if you got infected, we can't measure your immunity, but it might be lasting as long as 10 months. Now, it might go on longer. And by the way, a lot of people are clearly not immune after just a few months and have demonstrated the ability to be reinfected. That happens. But if this new variant, if its latest perfection, its latest innovation is to now elude the immune system, then what? Then does living with constant infection and reinfection with the latest version of the coronavirus become humanity's new normal? Possibly. And if you understand that actually every single human being is now producing with Delta up to 1 trillion, I mean, it's mind blowing, 1 trillion replicative events. And that every replicative event is a chance for a new innovation, because that's how it works. Life finds a way. We have a big fat monkey brain up here.
Yeah, I said that a lot.
We can outsmart this non-cognitive little strand of RNA, but we're going to have to work as a collective to do it. And I don't know, maybe if you ask me what I've learned in the pandemic, maybe those are my two lessons. I'm absolutely floored by the scientific advancement and the pace with which we were able to make it. I mean, if you just compare it to HIV, Jake, I mean, from the time that we first recognized young men in San Francisco were getting pneumocystis pneumonia and young men in New York were getting Kaposi sarcoma, we didn't even identify the virus until, that was in 81, until 84. And we didn't even have a test until 85. And the first treatments weren't until almost a decade after those first cases were reported. I mean, everything with this pandemic has been so fast forward. And so it's been an amazing triumph of science over disease. And it has exposed and highlighted so on the one side, the cognitive part of the human mind to actually overcome something that was whether, I don't care where it came from,
Yeah,
bioweapon, bat, I just know we got to deal with it. The ability of the cognitive side of our brain to take it on and actually whip it, amazing. And the ability of the non-cognitive side of our brain to get in our way, potentially. And the unique ways in which we apply risk and the biases that we have. It's just been, as a student of thinking, Jake, it's been a fascinating 18 months.
absolutely. Hey, Dr. Souza, I'm doing a time check right now. I thank you so much for coming on the podcast. Thanks for sharing your perspective. I appreciate the opportunity for a long form conversation to be able to ask questions I'm sure is on a lot of people's minds. Appreciate your openness and all the things that you do for our community. And I look forward to the next time you and I get an opportunity to say hi.
Awesome. Thanks, Jake. And I'm happy to talk to anybody anytime and have a conversation.
Yes, sir. Thank you.
See you, Jake.